Let's kick off. So, any talks that we had today, you can discuss points or questions. Oh, okay, Santosh, yeah.
Just, I think, wanted to mention about Kevin's last lecture about the medical legal aspect. Recently, we had a couple of days back, we had a transport leads meeting, and then the question arose whether the transport team should provide phototherapy during transport for a baby while going for a double volume exchange transfusion. In the country, I think still there are few transport teams who provide phototherapy during transport of the baby. Majority of the teams still do not provide. So that is one point. The second point also somebody arose, would a double volume exchange transfusion be safe to do in a level 1 unit, or whether the baby should be transferred to a level 3 unit for an appropriate exchange transfusion. Again, I think the verdict was, I think the people say that it should be like an emergency procedure, should be done in an emergency team if there is a delay. But I think the opinion is still quite divided, because we still consider double volume exchange as an intensive care procedure. So whether you should let that happen in a level 1 unit, thinking of all the consequences that can happen. So I wanted to bring that into account about the transport scenarios, what we face around the country as well.
2 points. I mean, it's technically possible to give phototherapy in most ambulances and transports. You've got your electricity, and we've used it on occasion. Which bit of kit you use, or whether you use a fibre optic pad and an overhead lamp, there's no reason you shouldn't. It should be a pretty rare instance, though, because it ties in with your second question, that you should be ferrying a baby around who's got such a critical level of serum bilirubin that you're needing to give phototherapy during the ambulance journey. You know, if the ambulance journey is an hour, it's probably not make a difference to switch it off. If the ambulance journey is 2, 3, 4 hours, it may well do. Or the example I gave of this baby sitting in a London A&E and not being transported across London for several hours, and it wasn't even getting phototherapy in the A&E, that's intolerable. So I think the answer is, to your question about the transport, it should be something a transport team looks into in case they have to do it on a very rare occasion. And I'm more for, I know you said level 1, but I'm not sure you meant level 1, level 2, as opposed to tertiary. I think we're de-skilling people, unfortunately, by the centralisation. This is one of the key areas where we have done so, and I would encourage the consultants and the juniors that rotate through those hospitals to come on skills days where you go through an exchange transfusion, because it's a similar argument to starting cooling, perhaps, as well. It should be able to do these things. Then you transfer the baby when it's stable. I would much prefer a baby to have its exchange promptly by a team, getting advice from a tertiary centre, or even the tertiary centre sending a registrar out to assist, than sitting in an ambulance not getting the right treatment.
It just brings to mind what a couple of cases I've seen, but particularly the not routine babies, the nocturne babies, surgical babies, preterm babies, hydropic babies, where everyone is completely focused on that particular condition and not thinking about the bilirubin. And as you know, it hasn't featured, albumin doesn't feature in Americanized guidelines. I'm not as familiar with the American guidelines. Should it be, and it probably doesn't feature in those who look after those surgical babies, or we don't think about it as much perhaps as we should. Do you think there's scope for it being an addendum, or should we, well, I suppose the question is, should we be treating with albumin before we ever get to that point? Or is it, should we be considering subgroups?
Treating with albumin is controversial in itself. I'm not sure that necessarily helps it. It's more being more proactive in intervening at an earlier level with your phototherapy and your exchange. Some of the old preparations of albumin contained chemicals which provide heat resistance to when the albumin was being treated, but actually those chemicals sat on exactly the same binding sites as bilirubin. So potentially could have been dangerous if you gave that albumin. They eluted off and pushed bilirubin off the baby's albumin. So, and there's no good evidence, I'll be contradicted by Vinny if he knows. I think there were some studies attempting to show that priming with albumin before exchanges is beneficial, and we didn't find enough evidence to suggest that. I don't think you can't make an addendum to NICE because you can't budge NICE without evidence. That's kind of why I fell off the perch with NICE. But
I just think there's potential to miss and to, the real step.
I think it comes from teaching days. And you're right, surgeons, there are cases where a baby gets jolly sick, gets transferred to a surgical unit, and bilirubin just is not on the radar of this 26-weeker with neck.
Or even a term baby with very high problem.
I think the issue of a baby going through surgery is a very important one. Because once the baby is out of the direct medical jurisdiction of the neonatologist, it's amazing how rapidly the albumin falls post-surgery. I mean, we've just seen it just last week in a baby who had a heart surgery done. And then the need to change your bilirubin thresholds based on that, and just using a bilirubin-albumin ratio at least as a guide. Also, as they go through surgery, I mean, there's a certain amount of DIC that happens, and there's hemolysis that is taking place. So we miss hemolysis, or if the baby has been put on an ECMO pump and so on. So all of those things need to be considered and revisited, and I think as we take care of more fragile babies with different surgical issues, I mean, that's one of the reasons we're trying to create the bilirubin panel. And endorse no albumin before exchange, absolutely not.
Sarah?
Yes, I was very interested in your reduction in phototherapy that you presented earlier on. And obviously that has an impact both on the baby and on the parent's experience.
Yeah.
And I just wondered how widespread that is and how that could translate to the UK population.
Well, what I have at the moment is a hypothesis, and I think seeing the variation in the use of phototherapy in different practices, and with shifting the at-risk baby's management to pre-discharge versus post-discharge, so that getting the baby in the first 48 hours to be treated with phototherapy to change the trajectory of the rate of rise of bilirubin. I mean, that has been proven. I mean, that's one of our nursing journal articles that we wrote many years ago when we implemented universal bilirubin screening at our facility. I think the mathematics works out because a small group of babies are to be treated, but we do have to prove that point. And I think we have a long way to get to a point where we can actually reduce the rate of readmission. And so there have been a few studies that have shown the reduction in the rate of readmission for hyperbilirubinemia and separating the mother from the baby and not disrupting breastfeeding. So it'll be nice to see more studies related to in different communities.
Okay, Paul?
I'd just like to thank all three speakers for a great talk. Karen, could I actually please, have you seen many cases come your way, medico-legally, where the exchange has been done in a timely fashion, but the child still got damaged? And could you give us a sense of the time-dose relationship between it? It's not just the level, it's the duration that the brain is exposed, I guess.
Yes, and you've heard about a lot of variables today. As the variable of the genetic makeup of the baby and their resilience to bilirubin neurotoxicity might come into that as well. But yes, I think it's fairly clear that you can have a very high serum bilirubin level. Let's just pick out 700 micromoles per litre acutely, that comes down again. I showed you that picture of the G6PD where there was probably a trigger of favism. That went up to about 655. If it's treated very promptly, that baby may well do better or be entirely normal compared with a baby who has a serum bilirubin of, say, 550 for 3 days, where the sort of area under the graph or the tonnage exposed to bilirubin causes the damage. Your point was, have I seen babies who've had the exchange who've still gone on to develop problems? Yes, I have, but the cutoff often is how long have acute signs of bilirubin encephalopathy been there. So if the baby has been having seizures and back arching for several hours, and it's a bit like Vinod's paper on the crash cart approach to it, then you're less likely to totally retrieve that situation. If the baby has just been irritable, had a few apneas, not actually back arching at that point, and you get it within a number of hours, you may have a completely normal outcome, or you may have just deafness. And it's very variable what picture you can have. But at the end of the day, you may ameliorate the damage. One would always, even if a baby was fitting, you wouldn't say, well, there's no point in doing exchange now. You may improve the situation.
If I may add on, because I've been doing this in the US and as well as in other areas, asked by the lawyers because they want to kind of time the disease with a level, and we know that bilirubin is not the best threshold to assess risk. Just to remind ourselves, just because the bilirubin value is low doesn't mean the baby is not going to have connectress. The baby who's getting readmitted with a high bilirubin value is a point in time that you're actually seeing the bilirubin value. You do not know what the preceding number is. And there have been enough case reports of babies whose bilirubin levels were high while under medical supervision, waiting to get treatment, and the bilirubin levels have plummeted, and the babies have signs of moderate acute bilirubin encephalopathy, the arching of the back and the fits. And that's when the drop in bilirubin has occurred. You're still seeing a high number. You may see 500, but it may have been 600 before that. And the reason for that is that if the blood-brain barrier is disrupted, and now there's free unbound bilirubin going on, it will lower the bilirubin because now the bilirubin has all this wonderful basal ganglia material to latch itself on. And so you'll have more symptomatology. So a low number should not be reassuring without unless there has been an intervention.
I would agree with that. Anecdotally, I've seen cases like that. When it drops, it's sometimes an ominous sign.
Are folks using IVIG in the US and in the UK?
Yes.
Yeah, obviously, in the context of rhesus disease, sometimes ABO that's come in a bit late, and I think it's quite right, and I didn't make that point to give. If you know you're dealing with hemolysis that's due to isoimmunization, that in the period that you're waiting to get the blood or you're getting the lines in, that it's quite a good. I think it's good practice to give IVIG then, even if it's just 2 hours, even if you're going to go on and do an exchange transfusion. And if after the exchange transfusion the bilirubin bounces up again, you'd give more IVIG because you've washed a lot of it out with the exchange anyway. So we do tend to, more in rhesus disease. I think that number needed to treat in ABO was a little bit flattering because the actual exchange levels they used weren't particularly high, and also I'm not sure how efficient their phototherapy was. My experience is with most ABOs, unless they've come in from home very late, you get away with phototherapy. But
Kevin, I think actually it's a year or two ago. Do we know the lowest level at which connectress has occurred in a normal, healthy breastfeeding baby?
From our registry of babies from 35 weeks of gestation and above, the lowest number was 20.8 milligrams per deciliter, which is like 330. All right. We did not know the albumin value in that baby. All right. So because there's no routine practice to check an albumin value, I mean, that's one of the issues. So that's why the reasons in our phototherapy kind of guidelines are internal consistency was to look at a bilirubin-albumin ratio and make sure the numbers match an albumin value of 3 or more.
It's interesting that, Kevin, you were talking about in 2010 that there was no evidence about albumin. And, we had a lot from both of you about the importance of albumin and didn't go into the guidelines.
well, there haven't been trials. There haven't been randomized trials.
And there have been no devices to measure unbound bilirubin accurately either, other than the Japanese data.
Yeah.
Santosh?
I think going back to that IVIG issue, I think when you've got an ABO setup or RH setup and we've got a DAT positive, then things is much easier. Occasionally, I think we have come across situations where those things are all negative, but still you have got a bilirubin in an exchange transfusion level. Would you still recommend IVIG in those situations?
So I don't rely on the DAT at all, unless it's positive, and then it just tells me that it's positive. It doesn't tell me how much hemolysis is going on. So I'm looking at the rate of rise of bilirubin. So if I'm trying to prevent an exchange transfusion and I'm preparing for the exchange, I don't want neurological signs to appear, yes, I will use IVIG regardless, because I'll see a blood group incompatibility. Mother is O, baby is A, There's no question in that mind. But I'm less likely to use IVIG to be a point of saying that to minimize the duration of phototherapy, that there is an AB incompatibility, and let me use IVIG rather than use phototherapy for 48 or 72 hours. That to me is a little mismatch in risk-benefit value, because I'm not sure what all the risks are with IVIG at this point.
My practice would be ideally to demonstrate that there was hemolysis caused by antibodies going on, because it's not without risk giving pooled blood sample IVIG. Maybe that's an instance where I don't have experience of using end-tidal carbon monoxide at all. That's why you didn't hear me mention the word. Maybe that's an indication where acutely with a baby like that, if you then showed the baby was hemolyzing with a 4 parts per million of end-tidal carbon monoxide, it would add weight to your decision to give IVIG, and you've got a result in 5 minutes. I'd just be interested to know, because as I say, I'm still sitting on the fence a little bit on end-tidal carbon monoxide and where it's going to take us in neonatology and approach to babies with jaundice, and I'm attracted by the idea of a panel of tests. But I wonder what your views are, having heard particularly Vinod's experience through his trials and also Ang's experience through actually using it. Are you interested in using it? Can you see a group of babies that you would be inclined to say, right, I'd like to, the baby that comes in with a high jaundice, would it be a help to you?
Definitely, that would be, it's an additional tool to guide you, isn't it? So rather than just what you have at present.
Luke?
I'm a general pediatrician who still looks after newborn babies, and majority of newborn babies are looked after by people like me, not by eminent neonatologists like you. That's really very important, really, who looks after majority of newborns in any system across the world. Now, and there's a lot of take-home messages for me to go and share with my colleagues, and one of the take-home messages is early detection of hemolysis, which seems, and the panel, which I think Professor Bhatani is trying to work out, and that could be something would be very interesting. We come up with high risk factors and the panel, which really help us, a lot of really people like us, who are not the experts, but still, and with a busy unit, multiple problems, surgical babies, all these kind of problems. Workforce skills is another important, really limiting factor. Now, I suspect that this kind of work must be happening in other centers, because Oxford, Medway, and your center, I don't think would be able to change the practice across globally. So, one, I think I want to have a reassurance, yes, there's something happening across the globe. And number two, how quickly you are likely to get this?
So, do you want to say? All right. So let me deal with this from a historical fact. I was one of the first few individuals who promoted the idea of universal bilirubin screening. And it did not happen because I was a neonatologist. I was working as a pediatrician in the well baby nursery, and things happened in our political system in the US where babies were going home at 24 hours of age. And my mentor at that time, Lois Johnson, wanted to make sure that every baby had a bilirubin done. And so we said, yes, boss, okay, no problem, you know. And so we ordered universal bilirubin screening whenever the baby had a metabolic screening done. So it was no extra heel prick, this was not work intensive. And so we had numbers. And then I said to Lois, now what does this number mean, you know? And that's what started the nomogram. And then we found that it was useful because babies were not discharged at 24 hours. The lab technicians could not get the bilirubin done at 24 hours. It just varied all over the place. And so then there were no statistics to use. And so all we did was apply statistics, and the nomogram developed. So to get that practice transitioned in the US took a huge battle, because it was a change in practice of something that was entrenched, which was a kinder, gentler approach. Leave the babies alone, and why the hell are you medicalizing a well baby care? And there were enough moms out there who had been hurt by this that they provided me the emotional backing that I needed the advocacy that I needed. But it was also a computer-age technology that was starting off, where we could put this nomogram on a Billy tool, and that it made it easier so that a person had it on their phone and they could make a clinical practice. And it was meant to reassure, all right? The idea was not necessarily to identify all the sick babies. The idea was to reassure that you don't have to worry about this baby. Okay, and that's more important, because what you and I don't want is a decision regret. All right? We don't want to send the baby home, nor see the baby for 3 or 4 days, and say, oh my God, I should have done something different, or why wasn't I thinking? All right? So that was the idea with the bilirubin testing. With hemolysis, there's a little bit of an intellectual component, because now that I've identified hemolysis, the question is, what do I need to do about it? So I do have some open questions that I've listed. But I'm looking to see how we can put it into our practice. So at our site, because we do routine pulse oximeter screening on every baby, this is no additional workflow. Had there been no routine oxygen testing in our well baby nurseries, I may have had more of a challenge because of workflow issues. And with that, we'll accumulate evidence. So should it be targeted or should it be universal? At the moment, I'm agnostic to that. I don't think it should be universal. I think it needs to begin as a targeted way, which is why for bilirubins above the 75th percentile, where I have to think that I'm going to need phototherapy, where I think I'm going to do an intervention, or where I need to follow the baby more closely and have the mother come back in the US to our offices, that's an extra trip. It helps in that judgment. So this is an aid to a judgment. I hope that helps.
Thank you.
Kevin, you have comments?
No, I couldn't better that answer from Professor Tom.
It's a complex one.
Yeah.
So, thank you.
You want to use HIV, you never have problem with your drug agency, national agency, because in France it's not, we are all beyond authorization.
Yeah.
So each time we want to do this, it's sometimes a problem, not for us because we are a reference center, but for other hospitals around or in other region in France, because the National Drug Agency says there is not enough HIV. I mean, it's a product which is sometimes in rupture, and also because there is no real demonstration, and you have other tools like exchange transfusion, for example.
Okay, in the UK, we have to put in a special request. I'm just speaking on behalf of my own hospital and our pharmacy. We have to put in a special request to get it, but it's been agreed by our trust board that this is a legitimate, useful use of IVIG. I think you should say to whoever's in authority that's preventing it that if their child comes into hospital with severe jaundice under phototherapy, do you want your child to have an infusion over 2 hours of this drug, or would you like us to replace twice its circulating blood volume with a risk of mortality of 3 in 1,000 and morbidity of 3 to 5%? They might change their mind.
Yes, it's what we wrote in an article. And also the problem is that the interns and fellows doesn't know how to do an exchange transfer.
That's right, absolutely.
So most of the time it's not exact. The first problem is to get the blood, because it's sometimes difficult to get because it's very centralized. And there is, even in Paris, there is only 2 centers which are providing the blood, and from some hospital in Paris region, they need 6 hours to get the blood.
That's a long time.
So we brought a procedure to do the blood, the total blood by yourself on the bedside, but people are very we are not very happy to do so. They think it's more risk. And the other thing is that in small and even in level 3, sometimes you have no doctor who knows about exchange transfusion.
Yeah, well, that's why I think it's valuable to have. You must have training days to teach your juniors how to intubate, how to put in a chest drain. Nobody puts in chest drains these days. So you have to have maybe rabbits or models dead rabbits. I hasten to add that you do that. And we do it. We have one station which is an exchange transfusion. So we have a dummy. And so you've got all the tubes with food colouring, red food colouring in the water, and I do that. I always run that station. I have great fun. I love it. But I think you have to do it that way and just keep your juniors up to date with it.
I think we had the same experience. I did an exchange transfusion about 3 months ago after 5 years in California. And I was the only person who had some veteran memory of doing an exchange transfusion. And try you me, I was trying for that 4-hour mark, and it was really touch and go. Yeah. And had not the baby failed a hearing evaluation with a screener, that I would not have been even more aggressive, and we were able to get it done. But it's time intensive.
Paul?
Question for the panel, please. I'm interested in asphyxia as a risk factor for bilirubin encephalopathy.
Yeah.
If it truly is a risk factor, because I've seen loads of HIE cases, never yet seen a case of Camitra. If it truly is a risk factor, does the panel think that is because of the damage to the brain, affecting the blood-brain barrier, or could it be a direct hepatotoxic effect? Because we know that albumin falls in the wake of HIE babies over the first few days following HIE. Any thoughts on that, please?
So there was a paper written a long while ago by David Benaron and Frank Bowen on the effect of perinatal asphyxia and the fact that in asphyxiated babies you were less likely to see hyperbilirubinemia unless there was trauma. And the question was whether is the body using up a bilirubin as the antioxidant. So there was some thought related to that. Now, if the baby is jaundiced, I mean, we've seen enough babies with HIE that I really don't see very hyperbilirubinemic babies. But even though they are hypoalbuminemic, they may need little phototherapy. So I'm not convinced that asphyxia is a risk factor in causing the connectors. It's just that brain damage has occurred and then you have an additional reason. So we try to go back to the collaborative data that Tom Newman has looked at, and there were so few cases of babies with high bilirubin values and asphyxia that we could not get any good statistics out of it. And I don't think there's any such data set now.
I think that is an interesting point, because I sometimes tease the juniors and say, have you ever seen a baby that you've had to cool for 72 hours that you've also had to try and give phototherapy to?
Right.
And nobody has.
That's right.
You'd have to develop a cooling jacket that also had a fiber optic element to it.
Right.
Maybe it's just a time difference, because unless you're dealing with a hemolytic or a pathological jaundice, maybe you're not getting a peak bilirubin there. But it doesn't seem to be an issue. There's something suppressing jaundice in these babies that are also asphyxiated. It is an interesting point, that.
Okay. Question to the panel, please. So we've had heme oxygenase inhibitors for quite some time. Initial trials have happened nearly 20 years ago. So, going forwards in future, why haven't we sort of capitalized on that? Of course, there are concerns about side effects and long-term safety, but are things moving in that direction?
I think they've started to move. So the original work as done by Dr. Kapas was groundbreaking and pioneering, and he switched from protoporphyrin to mesoporphyrin because of the toxicities related to the protoporphyrin. When I applied for an IND to do the study that I reported, so that study was done about 14 years ago. That I reported just came out in press because I decided it needed to be out in press. We had planned a larger study, and that study was blessed by Jerry Lucy and all the other experts, And our threshold was to give the tinmesoporphyrin at the 75th percentile track. And because our results during interim analysis were so incredibly profound, and you saw those 100 cases that I shared with you, that the FDA convened an advisory board and felt that the side effects of the drugs were not well studied or known, that they actually stopped the trial. It's the first time ever that happened. All right. And they figured that since carnivorous was not a problem in the US, this drug should not be developed. And they could go and test it, which is a statement from the advisory board, in the developing world. So you can imagine my chagrin at that. Regardless, I have to say for the company, they went on to actually meet all the FDA requirements. So they have conducted phase 1A and B studies all over again to meet the stringent guidelines. Because truly, I mean, heme oxygenase inhibitor can be toxic. But here we're talking about a one single dose in a very small dosage level. And so I think the FDA meeting is this month, looking at their data so that they can go ahead to use it to prevent an exchange transfusion. The FDA has allowed the company to have the drug available to anybody for compassionate use, at least in the US, so they can ship the drug to you if your pharmacy is willing to have it. And there's another preparation. The zinc mesoporphyrins are also being developed at this time.
Do midwives have any comments? Any questions?
First of all, I'd like to say thank you very much. It's been fascinating, and it's, as a midwife, it's really interesting. And I'm thinking it's not just a matter of updating, I think, for all of the people here, multidisciplinary team, but it's thinking about how to get this information through the whole service, and therefore education. I mean, obviously, we've talked a lot about research, and that's obviously vital, but I'm also thinking about education and how to make sure that midwives fully understand a different kind of viewpoint, because it's much more the targeted approach rather than a very simple, oh, SBR's this, we'll do this, that and the other. It's much more preemptive, which I think is very exciting, but I think it will require us to think very differently and move away from just ticking boxes, but thinking much more. And that does require education and training, and it also requires time. And I'm very conscious my midwife colleagues are probably all feeling, oh, there's another task to do, how on earth would we begin to do it? And yet, I'm thinking it could mean less time, because the time's used better, but I think convincing everybody might be a little trickier.
It's in Medway, we do a monthly pediatric grand round, rotating between neonatologists, general pediatricians, and community pediatricians. Not even going into ETC or any details in per se, but just going through the 4 mechanisms about jaundice in a bit more details, and then to the updated NICE guidelines. And after the talk, my general pediatric, these are experienced pediatricians, they came to me saying that thank you for reminding us, we forgot about that, and just trying to, exactly you were saying about which babies due to what and which one can have both issues. So yeah, I absolutely agree. Because one thing, again, Michelle is in the audience, about the from the NHS England point of view, one of the a key project is trying to reduce term admissions. And we know that from Michelle's data and what we have done in our network as well, about the respiratory infection, jaundice, hypoglycemia being the 4 top conditions that readmission. So anything to manage those sort of babies and preventing coming back to the hospital, as Vinny said earlier, risk assessed targeted, I think this is a way forward, which I think the details, which how we translate those evidence, what is happening in US into UK is going to be, as a challenge and need a lot of consideration. But absolutely, you're right that Vinny already proving about if we get more assessment right, we might have to spend a bit more time at that particular time. But on the long run, I think it's going to reduce the phototherapy, everything else.
If I may just give a couple of, I really enjoyed what you were saying, and I'm very pleased to hear. Number one thing that we did in the American Academy of Pediatric Guidelines was, the first step was promote breastfeeding, because normally most of our colleagues think about breastfeeding and jaundice are not compatible with each other. And so promoting breastfeeding is a key, because that is the successful way to treat and manage newborn jaundice. So that was the first step that was listed in the guidelines. The second message we should take back home is that those of us who are involved in birthing a baby, that bruising sometimes is taken lightly. But in the Swedish study, as well as in many, many other studies, bruising always rises up as a major risk factor, because that causes hemolysis. So recognition of bruising, identification of them is an important component. Thank you very much.
Michelle?
I've got a question about never events. So there are some very vocal voices in the UK, parents really, whose children have suffered from connectors and are campaigning to make it a never event. And the patient safety team in England are responsible for agreeing whether something is a never event or not. And we've looked at this twice, and it hasn't met our criteria for never events, because one of the criteria is that there have to be enough system-wide barriers to make sure that that can't happen. And the general feeling is that there aren't enough system barriers. So I'm interested, because it is a never event in the US, what do you have that we don't have? Because it would be really good to see whether we can develop that.
We had very active parents who were able to convince the never event team. They were very strongly activists, and they had people from systems, Don Berwick and all, who were very supportive of their approach.
There's a hands up there, yeah?
This is just a comment really of what you said about documenting the advice that we're giving parents, because a lot of our babies are managed in the community. And I speak of experience going to court in a case of a baby who died of kernicterus, that we couldn't really say what we had said to parents, and she'd phoned the hospital and we'd apparently told her, don't worry, go back to sleep, and the midwife will come and see you in the morning. So it is a challenge to document the advice that we give to parents out in the community, because most of our babies are out in the community, and the cases that we get in terms of risk management are coming from community in quite poor conditions. So just want to pick up, that is a challenge really.
It's interesting. From the other side, I have also seen parents, because of the cell phone systems, have all the records of the phone calls they made and the attempts that they've made. So you match that with the number of phone calls made by parents with the absence of documentation on the other side, that doesn't speak well of us as a medical community.
Certainly from the recent CQC inspection, they'd actually pick up on where do you record, and it's absolutely impossible to document every single advice that you give. So in court we had to say that actually that our standard advice would be this. So it's unlikely that you said to the midwife, my baby's not feeding, that the midwife would have said, actually, don't worry, we'll come see you in the morning, so which was 12 hours later. So it's a very unfortunate incident, really.
I think that's very important, what you're saying about documentation. Parents will remember certain things and will forget other things. They will remember things like, oh, put your baby in the bay window in the sunlight, and this is the cases in recent years, and we know that's verboten now. Vinny's right, the parents will probably have a better record of things. They'll use their fancy phone to take photographs. I'm looking at a case at the moment where there's a dispute of fact as to whether a hospital restarted phototherapy during a certain day or not. And the parents have just bombarded me with photographs of this baby and them interacting. And there's not a bit of phototherapy equipment or iPad in sight, so they're using that. So it is very difficult, and it's very difficult if you're a busy job in the community to spell out the advice unless you give written advice. Then you've got the language difficulties quite often, and it's often chaos theory, that it's a bank holiday weekend, the baby goes home on a Friday, there's a different midwife goes in a Saturday, nobody can get there Sunday, someone else different goes on a Monday, the parents don't speak English, and that's why when you say, I'm disappointed we can't make this a never event, because I think it's an excuse to say, well, are there robust hurdles that mean it should be a never event? Well, there are robust hurdles about taking out the wrong kidney or chopping the wrong leg off, but it still happens. And I think it just would give much more credence to this policy and taking babies' lives much more seriously to make it a never event. And we should tackle that in term babies. Yes, in preterm babies, sometimes babies are so sick that unfortunately they do get damaged with bilirubin. Okay, I'm going to close the sessions, and so I hope you had interesting, informative, enjoyable day, and thank you for coming. I'd like to thank two distinguished speakers, Professor Bhutani and Dr. Ives, and thanks Capnia for supporting the event. So safe journey home. Thank you very much.